cover the letter H. We have heads and hearts to talk about today. You'll hear about headaches, and you'll hear about your heart. I'm going to introduce our first speaker, Dr. Deanna Genora, and allow her to speak about who she is, what she does, and what she wants to share with us.
Great. Thank you very much, Joanne. My pleasure to be here with you all today. Thank you for joining us. I'm going to see if we can get our slides going here and get rolling. So as Joanne said, my name is Deanna Genora. I'm on the faculty here at SOM in the Neuromusculoskeletal Institute. Hopefully you all can see that. And hopefully we feel a little bit better than this. All right. So my background is in physical medicine rehabilitation. So I had training in brain injury where we dealt with traumatic brain injury, post-concussive syndrome. And that's how I came to headache. So I had a lot of experience with patients that had a lot of post-trauma, a lot of post-concussive headaches, and then a lot of experience with Botox injections, which is how I sort of worked my way into headache, working with some of the practitioners that were here over the years. So kind of had a non-traditional headache entry. Most headache practitioners are from neurology or family medicine, but we can talk about that later. Let's see, my timer's rolling. Okay. So I have nothing to disclose except we will be talking about some brand names and into generic because I think it'll make it easier for you all to recognize some of the things that we talk about. When we talk about headache, the most important thing is that diagnosing headaches, and there's what they call primary headache disorders, which is the vast majority of things, and we're primarily going to be focusing on migraine, and I'll explain to you why, because it's by far the most common and the most debilitating headache disorder. But when you talk about migraine, there's actually 29 different migraine diagnoses. It's like somebody saying I have heart disease, or I have back pain. That's a general thing, or like I had food, so there's many different things that constitute headache, and there's many different things that constitute migraine. So there actually are some migraine diagnoses that don't even have a headache. You can actually have an abdominal migraine and only have nausea, and that's actually a migraine, and it's going to be treated differently. And these are going to be different than if you have red flags and have a secondary headache disorder, which are very few, but important because they can be significant in terms of emergent type things. These are some of the issues that obviously, when we see patients, we want to rule out those things because they can be important both emergently and you're going to be treating them completely differently. And like I said, we're not going to talk about them today because that's a whole other issue. This is an old slide, but the data still holds in that in terms of the prevalence of migraine and the disturbance that it holds compared to other neurologic disorders, which are significant, the numbers that migraine holds in the population bear to why it's a very important disease and disorder to discuss. Okay. The first thing when we see patients with migraine is we try and do the simplest things first, okay? Joanne, you'll probably love the top thing on there, right? So the first thing that we treat almost all of our patients are referred for OMT, or osteopathic manipulative therapy, not only because we're here at the School of SOM, but because it works, all right? It's extremely helpful because a lot of these patients are coming in with head pain, a lot of neck pain, a lot of muscular issues that come in to play with this, and it's extremely helpful. The doctors that are here at our university are experts, and that's what I tell the patients. These are world and experts that train everybody else. It's very, very helpful for this. There can be TMJ issues that play into this, so almost all of our patients are referred for this, and it can be very helpful. Yoga is extremely helpful. There's a lot of studies that show this. Even if you can't go to a yoga class, and this came in really handy in the last year, there's YouTube sites for at-home use. There's one in particular called Yoga with Adrienne, who does specific yoga for migraine, also yoga for neck pain. So we refer all of our patients that. It's free, it's at home, they're 20-minute sessions, so there's like literally no excuse not to do it. She has a really cute dog as well. We recommend tinted glasses and windows because of the photophobia. Not the blue light glasses that you get for the computer. They don't really work for migraine. It's actually literally a rose tinted glasses. They're called TheraSpecs is one of the companies, but sometimes we actually will write for patients to get tinted windows, both in their car as a medical necessity or at work. If you're sitting next to a really bright window that's coming in, or the lights at your desk are super bright, like the ones they like to use here, we can actually write as a medical necessity that that the patient has, tinted windows to help them. We do a lot of biofeedback relaxation therapy, and then we say no stress for you, because stress, of course, kicks off migraines, and that, The other thing that we go to as our next step are called nutraceutical, right? So vitamins and things, because the risk benefit is really helpful with this. These are some of the most common ones. Coenzyme Q, which is an antioxidant, has actually had a few randomized controlled trials. So in terms of being helpful for migraine prevention. So you have to take these on a daily basis, not when you get the headache. But again, most of these come in gummies. So you can make yourself a little pack of snacks to take. So most patients, the compliance goes up with these because there's really no downside except for the cost. So I tell them to get them on sale, where you can get them. So the coenzyme Q is really helpful. Magnesium oxide can be really helpful. Can also really helpful for specifically menstrual migraines and cramps. This one can be a little tricky because it can cause loose stools at higher doses. So depending on your patient population, if they have problems with constipation, this is a good one. If they have problems with loose stools or IBS, you have to be cautious here. Lower doses of this are safe in pregnancy. So if you have patients with headaches, this is a good one as well. Melatonin on a nightly basis can be good for headache prevention, but you can actually use higher doses if the patients can tolerate it for headache prevention. Now, some patients do great with this. Other patients report that they have adverse effects like dreams that are very vivid that they can't tolerate. So this one, they have to start low and kind of titrate up. And again, it's not as needed. It needs to be taken nightly. And the same thing with the vitamin B. So most patients we want on these kind of vitamin cocktails to help with them, in addition to talking about their diet and regular sleep and avoiding triggers, which are very specific for them. Beyond that, then we kind of go into the more medication type things. So when you think about migraine, you think about the triggers of migraine. So you have the trigeminal vascular system. And what that does is it releases what are called neuropeptides. So if you see all the pretty colored dots over here, there's different chemicals that are released, including one called CGRP, which we're going to talk a lot about later and spend the bulk of our time on it. And those chemicals activate the sensory fibers in the brain that go to the thalamus that then activates what's called a cortical spreading depression. So it's basically a wave of electronic things that go across your brain that basically make the pain wave, kind of like the waves in the ocean, only not in the nice way, that make the pain kind of pulse through your brain. And they've done studies on this that show it both in animal models and in people. So if you think about this, migraine is not just an isolated neurologic problem. It really is a whole spread throughout the neurologic system. In the past, what they knew in the 90s, this is kind of where the basis of the treatment of migraine was triptans. And if you know anything about migraine, you've probably heard of triptans, like sumatriptan or Imitrex is the brand name. Well, and that's been the mainstay of migraine treatment for the longest time. What happened is that the triptans are agonists of what's called this 5-HT, or it's one of the serotonin receptors. And what they do is they block this vasodilation, so you would get the throbbing of the vessels and stop the release of the neurotransmitters. The problem with that is that also blocks the vasculature in the brain. So the vasculature in the brain, if you block it, and the heart, if you block it too much, you can get vasoconstriction. So there are some serious issues with triptans with patients that have any issues in the brain or in the coronary circulation. Back to your heart there, Joanne, right? Heads and hearts. So if you have any issues with the circulation, like if you had an MI or an aneurysm, or if you've had a stroke before or a heart attack or any surgery on those, then those patients cannot take this mainstay of treatment. For a lot of patients, these work fantastic and they work great and they've been, life-saving. But there are whole hordes of patients that they've been contraindicated for. They also have a not insignificant list of adverse reactions, many of which are vascular, that you look up. So there are some limitations in terms of their usage. A lot of patients get fatigued or get dizziness or they get palpitations or flushing with that. So while for a lot of patients, these have been and still are great, there are some significant limits with their usage. But that was all we had since the 90s until a few years ago. If you couldn't take triptans or they didn't work for you, you were either out of luck, and you had to lay in your room in the dark with ice on your head, or you had to take some kind of a pain medicine, just to kind of blunt the pain, and that was it. Besides, so these are some of the guidelines, and these are for children and adolescents, but I put them up because they were the most recent ones from the American Academy of Neurology in terms of how to use triptans. So triptans had to be taken very early in the headache. If you waited and you weren't sure it was a migraine, or you tried to tough it out and you waited too late and the vasodilation already happened, it wouldn't work. There were limits to how many you could take, and then again, the vascular issues. And if you had hemiplegic migraine or any neurologic symptoms at all, like any paresthesias, you couldn't take these. So there were significant limits. Besides the triptans, the other thing that we had until recently in terms of prevention, so the triptans were for acute treatment. The preventatives that they had were not at all specific for migraine. And you can see this is from a study from the 2012 guidelines that they did from the AAN that had levels of evidence in terms of migraine preventives. And all of these medications are not migraine specific. You can see there were antidepressants, antihypertensives, anti-epileptic drugs, none of which have anything to do with headache, okay? But that was what we had to use until recently for headache. And what we would do is we would pick the medication that we thought would have the least side effects in that particular patient, right? Not a great way to treat headaches. That was what we had. And these were the FDA approved medications for migraine. Divalproate, right? Again, lots of side effects. Topiramate would work great for a lot of people. One of the side effects was weight loss. That was not a hard sell, but kidney stones, not great, right? And again, a lot of cognitive side effects. Propranolol, if you had young women that had already low blood pressure, not tolerated very well. If you had older people with cardiac disease, then that might work for you. So you had to pick these medications based on the side effects. But what has happened in the last 10 years, research-wise, and about 5 years clinically, is that there's been absolutely a revolution in migraine. And the revolution is called CGRP, or calcitonin gene-related peptide. And what they found out is that this neuropeptide was elevated in patients when they had migraine, and when it was dropped, they didn't have migraine. So they said, well, what happens if we block that? Let's try and block that neuropeptide. And what they found was that when they blocked that neuropeptide, the most bothersome symptoms of migraine, the pain, the nausea, the photophobia, the phonophobia, all went away if they blocked that neuropeptide. So what they did is they developed medications, both preventive and acute treatment, to block this CGRP molecule. And this is where we are today. These are the medications that I'm sure that you've seen advertised if you've been awake at all in the last couple of years. So these are some of the brand names and the generic names. The preventive medications are all monoclonal antibodies, so they all end in MAB. So you have erenumab, frenesimab, galcanezumab. These are the once-a-month injectable preventive medications that you see. They all have celebrity endorsements on TV, right? Those are used to prevent migraines. They come as like an EpiPen. It's a self-injectable that the patients use once a month to prevent your migraines. And then after that, they worked so well. What they did is they were able to research what are called small molecules, or GPANTs. They're all named. So ubrogepant and rimegepant, that you take when you have the migraine. So instead of the triptans, which have all the vascular issues, these molecules now do not have all the vascular issues. So we have other options instead. And then instead of all the non-specific beta blockers and anti-seizure medicines, now we have these CGRP blockers that can block those medications or block the CGRP molecules to prevent headaches. And then the second step is that we now actually have an IV infusion CGRP blocker. So for patients that can get this once every 3 months as an IV infusion to block that. And this is kind of what it looks like in picture. So we're going to stay on the left-hand side of this picture. So if you look at the CGRP receptor here, the Aimovig, which is this erenumab here, blocks the receptor. All of the other monoclonal antibodies block onto the CGRP ligand itself. So they block it so that it can't grab the receptor. So because it can't grab on here, it prevents migraines. All the other GPANTs, or small molecules, treat migraine when you have the migraine. So when you have a migraine, you'll take one of these medications over here by blocking the receptor. Okay. This on the right side is what's going to probably be the future in the next 5 years of another neurotransmitter that they have, this PACAP, right, or pituitary adenyl cyclates, antibody that they're working on now. So they actually have more things that are going to be coming. So it's really cool and exciting, right? These, again, just give you some more information about them, about how they work, about the doses and all kind of stuff like that. One of them can actually even be given quarterly if you want to give yourself 3 injections at a time. This is what they look like over here. Again, they look pretty much like an EpiPen. They have all kinds of patient education videos with that as well. This is just some more information. They have very low risk of side effects, including nausea and 2% nausea, 1% somnolence, much lower than the triptans. They all say avoid with hepatic disease and severe renal disease. They all have issues with strong CYP3A4 inhibitors. The biggest of which, of course, is the grapefruit. Antifungals, the verapamil, and some antibiotics. And then some other use things here. I'm just watching my time for you. Brand new, most recently, there's another GPANT molecule that's a daily oral preventive. So no more injections. This is a daily oral preventive. So again, it has all the same issues with the CYP3s and the same slightly higher risk of constipation because you're taking it more often. But again, this is kind of where we're treating migraine at this point. This is the IV CGRP antagonist again. Single treatment every 3 months. So better results, but higher risk of nasopharyngitis and also hypersensitivity of reactions with these. So again, it took patients that had resistant migraines and they got better results, but higher risk, which is kind of medicine, right? And then there's one other molecule called the lasmiditan or Rayvow, which works on a different 5-HT receptor. This one actually has higher risk of CNS sedation and has a driving restriction. So this is actually a category 5. This one is a harder sell to patients because if you tell them they can't drive for 8 hours, they're like, well, I might as well just have a migraine and lay down and take a nap. So I kind of saved this one for my really resistant patients that nothing else works on, but it is out there. So there's a whole this is all in the last 5 years. There's a whole host of things that didn't exist, before that. So it's really exciting. There are some studies out now that are doing head-to-head trials of these new medications compared to triptans. This one was actually a meta-analysis of the control trials, looking at these CGRP blockers. And they said that they were better than placebo, but had less relief than compared to triptans. And they look at pain relief at 2 hours. But considering the cardiovascular risk with triptans, you kind of have to look at that. So it's a patient-by-patient basis. The other thing is that you can take these CGRP antagonists and the triptans at the same time, like not necessarily at the same time, but on the same day. So I have a lot of patients that I actually, even if they can take a triptan, I'll prescribe this in addition because the triptans, you can only take like 3 days a week. I tell them I have like 3 strikes and you're out rule because you don't want to overtake it because even if you can take it, you don't want to over vasoconstrict. So I have the 3 strikes and you're out rule. So if you're taking it and you're still getting more headaches, then we'll give you 2 tools. I tell them it's like salt and pepper. Sometimes you use one, sometimes you use the other, sometimes you use them both together, and that's okay. The insurance company is, of course, the issue with this. Anyway, okay. So that's that. So moving on to something else. Another option we can use for migraine is botulinum toxin. This came out of its use in cosmetics. When people were getting their cosmetic treatments, their migraines also went away. You have to have failed 3 of the preventive or abortive therapies in order for your insurance to pay for this. But we do this down here. This has been in use probably at least 10 years. It works really great. We do it every 3 months. You can't get it more often than that because your body will recognize it as a foreign protein and fight against it, which doesn't help. You do get the cosmetic effects because the injections are similar. So I'm just saying, if you have a lot of headaches, we'll take care of both things at the same time. All right. Those are the sites that we do. The other things I wanted to mention is there are some neuromodulation devices. There's 4 different things that help your headaches. This is kind of like Wonder Woman, but it's actually does electric stimulation over your trigeminal nerves here, which is similar to Nerivio, which is an armband that does electric stimulation. This is a vagal nerve stimulator, and this is a transcutaneous magnetic stimulator that's like somebody coming up behind you and going pop in the back of the head. And all of these things both treat or prevent migraines, none of which are covered by insurance. But if we have patients that have funding and don't want to take medication, all of these things are FDA or approved for migraine treatment. Kind of cool. We also have anesthetic nerve blocks we can do when patients have acute headaches. So it kind of will shut off the headache. We use these a lot of patients, like with in pregnancy where they can't take medication and everything has to go off. These things can be used instead of oral prednisone. Like if you have an acute headache and you can't take steroids, we can use these nerve blocks. Combination with OMT works really well. Watching my time to make sure I don't go over with that kind of that. And then the other thing I wanted to mention, we can't talk about headaches without mentioning COVID. Obviously, as a symptom of COVID that has been there, but also post-COVID, headaches have been persisting. So patients, there's been about 20%, this is a study out of Europe, 20% of patients who've had COVID have continued to have headaches afterwards. And of those, more than 50% have been severe headaches. And we've seen this in our office where patients have come in and they go, I just can't get rid of this headache. All the other COVID symptoms might have gone away, but the headache persists. And as part of long COVID, that is one of the symptoms that they look at. All the programs around here, they're doing long COVID studies. Headache is one of the primary symptoms that persists with that. So acute COVID can trigger a headache similar to migraine extension, and we know that. The SARS-CoV-2 can exacerbate a pre-existing headache. If you had headache before, it tends to make it worse. It can cause new activation of the trigeminal vascular system. Okay, that's my that's my PBL kicking in for timing. So it can cause, and you can have persistent headache, and they think it might be due to altered levels of glutamate or hypoxic injury from post-COVID. So that's kind of a new thing that's coming out with headache now for us to keep our fund. So that's some more of the resources. Shout out to Cass Cahill, who's the nurse practitioner here before me, who really helped a lot with that, with developing our headache program here. So if anybody has any questions, I guess we can handle them now or later, however you want to do it, Joanne. So
we'll handle the questions at the end.
There you go. Okay.
But and if anyone has any questions, you can put them in the chat.
All right.
Okay, our next speaker has joined us, and she's the heart person. We already did the head, now we have the heart. So heart doctor, please introduce yourself and take it away.
All right, all those years of school and I figured out how to unmute myself finally. Okay. Thank you for the introduction. So I'm Hafeza Shaikh and I'm with Virtua Cardiology. So I've been affiliated with Rowan for umpteen years ago, I guess, since I did my fellowship. But that was a great presentation, Dr. Genora. Just wanted to let you know I learned a lot from that. And I have a question which I will hold until the end for you as well, too. So I just need a minute to get my screen shared here, and then I will be up and running. Sorry, almost there.
Dr. Shaikh, do you want me to share your presentation for you?
I think I have it now. Sorry, I just wanted to make sure I did it in the right screen. Okay, great. I am up and let me get it shared. I have to say I don't use a lot of WebEx. I'm a big Teams and Zoom user, but I'm learning quickly. Okay, great. And you can see that PowerPoint screen?
Yes.
Excellent, great. So I wanted to talk about a very timely topic, which is women and heart disease, because unfortunately, I think a lot of the press that happens around cardiovascular disease does not affect, is not discussed enough about our gender. So I have some nice statistics that should make you think and ponder for a little bit. Definitely would look forward to hearing your questions at the end of the presentation as well, too. And hope you have some good takeaways from this to take for both yourself and for your loved ones. But to begin, back in 1964, when they first discussed the Conference for Heart Disease, this is the demonstration that they used to have before, which was a way to a man's heart, a fat-controlled, low-cholesterol meal plan to reduce the risk of a heart attack. So, you know, a picture says a million words, and obviously we can see how the focus for heart disease really used to be centered more about men and not necessarily understanding enough about how much it afflicted women. So I'll show you some upcoming statistics, and you'll see how even when there was more recognition of women being afflicted by heart disease, that the diagnosis rates went up, the treatment got better, and the outcomes got better as well, too. But remember, this was only, 50, 60 years ago that this is how we were looking at it. So for a couple statistics, more than 43 million women are currently living with some form of cardiovascular disease. And it's a dangerous disease. It's not just present, but it's actually taking lives. Causes death in 1 in 3 women's death every year. And it does kill approximately 1 woman every minute. And the sad part is we always want to know what parts of disease are preventable, what parts of disease are predictable. So this way we can find out who's higher risk and take care of these things in a preventative fashion. 90% of women that do present with heart disease, they had some sort of a risk factor. So it goes a long way in terms of the ounce of prevention being worth a pound of cure, and just makes us all know that we do care about the risk factors, making sure those are addressed and investigated before something comes to a head. So since 1984, in fact, women have taken the lead, not in a good situation, but in terms of the actual deaths each year from heart disease. And that gap actually continues to widen, unfortunately. I think at some point we will eventually see at least a slowing of the gap. But again, that has to do with how well we are at diagnosing and catching heart disease as well, too. Symptoms can be different, and I'll go into that as well, too. And breast cancer and cancer is another very serious health topic that afflicts women as well too. The one, criticism is we don't do enough press about the heart disease for women, and we definitely need to make sure that we bring that to light more. So this way, it's a conversation piece, and it's a conversation topic that is on everybody's conscious. So here is the mortality rates, and this is what I wanted to show you too in terms of the stats. The actual mortality rate, this is unacceptable, right? We're in the year 2021 with some of the best diagnostic technology that we have, both in terms of non-invasive imaging, in terms of blood work as well too, and then of course treatment options as well. So we need to get this mortality rate down, and we have all the preventative tools. We just need to make it happen. I also want to bring up the stroke numbers that are on this chart as well too. Stroke is another vascular disease. So cardiovascular means we're caring not just for the heart, but also the blood vessels in the rest of the body. And the blood vessels in the brain, or in the main blood vessels that lead up to the brain, are commonly implicated in the cause of stroke as well too. But all the risk factors are almost identical between them, which means we can almost take care of preventing 2 diseases at the same time. So while we're here, only 1 in 5 American women actually believe that heart disease is their greatest health threat. So I am Jersey born and raised. If anybody wants to raise their hand on the little emoji there, do we have any other native Jerseyans? Yes, excellent. So Jersey born and raised. Unfortunately, you're not going to be proud of these New Jersey statistics that I'm about to show, but heart disease and stroke account for 32% of female deaths. Each day, it's about 31 women that actually pass from heart disease and stroke here in our state, and 10,000 female deaths per year are approximated. This statistic is unfortunately very upsetting as well too, which is that nearly 53% of women in New Jersey are obese or overweight. So we know that that then contributes to blood pressure, cholesterol, prediabetes, diabetes, and unfortunately puts everything together as well with something called metabolic syndrome, which has also been independently investigated to be a very significant risk factor for heart disease as well. And smoking, 13.2%. We've got to get that down. And again, a lot of the focus sometimes around cigarettes could lead to more of a cancerous discussion. But I do like to just make sure that people also know about the implications of emphysema and long-term lung disease, which a lot of times is not reversible at all. And in addition, vascular disease and cardiac disease as well. So in terms of obesity, how bad? How do you assign a value to exactly how dangerous it is? It is very dangerous. So the top of the image here shows a scale, which is reflecting the risk of obesity in terms of the years that somebody remains obese for. And the factor is pretty bad, 1.25. So, I always try to emphasize with people as well, too, there's certain factors that we can't control. We can't control our genetics or what type of heart disease or anything that we were born with. But what we can do is just make sure that the factors that we can control, including tobacco and obesity and acquired diseases, to try to make sure. So I do a lot of referrals to nutrition. You know, if you don't already know, your own medical insurance will cover you to see a nutritionist, depending on the specific insurance and the medical conditions. There's a certain amount of visits per year, but the resource is out there. So I think we need to make sure that everybody knows that those are available and that somebody's not alone and when they're trying to control these risk factors. So what is atherosclerosis? This is when, you know, oftentimes we hear hardening of the arteries, or, oh, my grandmother passed because her arteries had a lot of plaque in them. So that is atherosclerosis. It's when the plaque builds up in the walls of the arteries. And if you want to hear something really sad, when they do pathology and do tests, even the diet that we have in our 20s and 30s starts to make tangible changes in the blood vessels, even in your 20s and 30s. So they call it the fatty streak. And that's the initial part of how atherosclerosis starts. So basically within the blood vessel, which is essentially a small tunnel connecting the blood flow and making sure that your heart is able to pump the blood flow to your vital organs, those tubes and those arteries, they begin to get this white fatty streak, it's called, that builds up, and eventually that just grows upon itself until plaque builds up. Plaque will build up to the point where when it starts to impinge on enough of the diameter of the blood vessel, that now you're in trouble. Now we're going to notice that the kidneys are seeing this damage, or that you're feeling a symptom of heart disease or blockage or a circulation issue anywhere else in your body as well. So that builds up, it makes the blood, it makes it harder for the blood to flow through. And then on top of it, a blood clot can form. And that is actually what causes a heart attack, is when that circulation is totally cut off, because we had that initial irritation, atherosclerosis, and now a blood clot comes along and actually cuts off the circulation altogether. So I have a question for everybody as well, too, just to make sure you're awake during your lunch hour. Coronary heart disease develops gradually over many years and can easily go undetected. True or false? Great. I got a response in the chat from Rashida, true, and from Diane as well, too, and Andy. And Adora, let me know if I pronounced that terribly or not. I apologize. Great. So yeah, so hopefully I kind of handed this to you. But again, when people say, why did this happen to me? Why did heart disease happen? It's a continuum, and it really builds over the years and decades. A heart attack can happen all of a sudden and be an overnight event. But again, the heart disease and the predisposing situation does develop gradually over time. So coronary heart disease takes years to develop, almost a decade. And honestly, by the time that time comes, when people are maybe, in 50s or 60s, then there's a whole other slew of concerns, things like osteoporosis, arthritis, and cancer. And then these just actually detract the attention from getting a proper cardiac evaluation. Here's another true or false. Women don't have to worry about cardiovascular disease. It's primarily a man's problem. So, I tried to hand that to you as well, too. Excellent, Rashida, with the false. And April as well. Thank you. Absolutely. So it is the #1 killer of women, and there's more women that die from heart disease and stroke than do men. So here is a graph over the years as well. And again, we're hoping to see that the white line of the females does start to downtrend eventually to the way that the red line is. And hopefully we will get there. This is another breakdown of the leading causes of death among women. So this should be a conversation piece. This is something that not just everybody here, but going back to your loved one and your friends to discuss and just say, hey, listen, have you had your risk factors looked at? And I'll go into those risk factors. Have you had an evaluation? Do you ever feel something that doesn't seem right? Until it's a conversation piece, we're never going to get a good grasp on the prevention aspect. And another true or false here, if a woman has a heart attack, she's more likely to survive than a man. This one I didn't totally hand to you. See what the audience has to say. We got a few falses. Okay, so you're getting my general theme here, I see. So yes, so unfortunately, she is less likely to survive. Why is that? There's a couple theories behind it. One is the thought that maybe a woman actually had symptoms that were occurring for a little while longer before she sought attention for a multitude of reasons, either saying, oh no, I'm sure it's just stress, or hey, I'm too busy to pay attention to my body and what's going on too. It's a multitude of reasons, but unfortunately, survival and mortality and long-term effects are implicated in this. So studies show that 23% of women may die within a year as compared to 18%. So it's crucial. It's not just what we say primary prevention of making sure that the disease never onsets, but also that secondary prevention of making sure that another event doesn't happen or a complication. At older ages, the statistic is actually double, that women who have had heart attacks are twice as likely to die from them within a few weeks. As per a 2012 report, 64% of women who die suddenly of coronary disease did not have any symptoms that we knew of beforehand. So this is a little bit of the symptoms which I alluded to before too. So, you may have heard that women get atypical symptoms or may not feel the same symptoms. Well, what does that mean? How do I know if I have a headache? How do I know that that's not a heart issue, right? So the most common textbook symptoms for having heart disease are going to be things like pain, pressure, discomfort in the chest, anything of that nature. Also shortness of breath or shortness of breath on exertion. And oftentimes a lot of these symptoms will happen when one is exerting themselves, because that's when more demand is being called on by the heart muscle. We're exercising, so now the blood flow through your leg and skeletal muscles is double, triple what it was when you were not exercising. So now the heart, as the main pump, including the left ventricle, which is the big pumping chamber of the heart, needs to be able to put up with this. But in women, it could be other things. I've gotten fatigue, I've gotten lethargy, just inability to complete the same activities that one could complete before. I've heard from people. I've also heard just kind of non-specific, even, lightheadedness with exertion could happen as well. Sometimes it may seem like it's more of a heartburn etiology or anything like that too. But the main point is get it checked out. It's a big price for the guesswork in this range. So typically atypical neck, shoulder, upper back, abdominal discomfort, which does happen in a lot of female patients as well too, where it can feel like it's more of an epigastric or abdominal area, nausea or vomiting, sweating, and then some of the other factors I mentioned as well. So the point is the symptoms can be more subtle than just, hey, chest pain, I feel an elephant on my chest. Women tend to have blockages, not just in the main coronary arteries, but they also can occur in some of the other smaller arteries. So just to give you a breakdown, the heart has three main coronary arteries. One of them on the front is called the Widowmaker, which is that runs down the anterior, the front wall of the heart, one on the side and one on the bottom. So those are the main arteries that are investigated during heart procedures, and stents can be easily placed in them. But there's a whole nother slew of disease that can happen too, which is called microvascular dysfunction and even myocardial bridging, which means this is actually affecting the smaller arteries. Sometimes it can't even be treated with a stent. It has to be treated with medicine. So true or false here, women are more likely to get heart disease after menopause. Isn't that's the golden years, right? Aren't we supposed to be doing better in those years? Excellent. Yeah. So what happens? Estrogen. We lose our estrogen. And before then, that's why the heart disease rates in women premenopausal ages do tend to run of a lower frequency as compared to afterwards. So estrogen, it affects our cholesterol. It raises our good cholesterol, which is the HDL, and it lowers our bad cholesterol, which is the LDL. So menopause obviously is a very variable age for different people, but it is around age 50 that things do start to change. And this is when you start to see a fluctuation in the cholesterol levels. So in general, cholesterol levels should be checked on either an annual or biannual basis, depending on your other risk factors, depending on things that I'll go into in terms of blood pressure, tobacco usage, your weight, like we had mentioned as well too. But the loss of estrogen is the biggest culprit for why that happens. So I give this one to you too, but when men reach middle age or 55, their cholesterol rises, but women's stays the same. And that is not true, because they actually become stable for men around 55, but for women, it goes up. Here's another question. African American females are more likely than white females to die from coronary heart disease or stroke. Excellent. Thank you. Thank you. You gals are awesome in the audience participation. So the death rate, 35% higher. My goodness. So 35%. Again, unacceptable, right? It's 2021. We have the best technology and communication portals than we ever had before. But African American females also twice as likely to have a stroke and also have a higher risk of dying than Caucasian females. So which of the following is the single most important thing that a woman can do to reduce her risk of a heart attack? Reduce stress. Good luck, right? That's what I say when people say that. Reduce stress, start jogging, reduce salt in the diet, or quit smoking. What do you think is the most important risk factor that gets modified that can make an impact on the risk score calculator? Smoking. You got it. You got it. So smoking it is. It's the single greatest preventable cause of death. And in women in particular, it is the biggest preventable risk factor for heart attack and stroke. So women smokers double their chances of having a heart attack over women who don't smoke. And that is correct. It's about double the chance. There is so much to talk about in this slide. This would not fit in this presentation. Just kind of going through, and I think it is important to go through too, because often, the thought is, oh, well, if I use some alternate type of tobacco, or I have a lot of patients that actually make their own cigarettes as well too. Well, I know what's going in there and it's not that bad. Every single ingredient terrible. So if you have any loved ones, male or female, that you're still working on, feel free to send a screenshot of this graph to them as well, just to have them work on that. But yes, so many of these ingredients, they may narrow the blood vessels, they may cause the heart rate to go up, they may cause the blood pressure to go up over the years. So unfortunately, so many ingredients here can be really adverse to that. And women can actually reduce their risk of a heart attack or stroke by quitting smoking, but also exercising regularly, eating a healthy diet. Obviously, these are all factors that need to be addressed. Many of the risk factors for cardiovascular disease are actually controllable, right? The genetic component, they're the cards that we were dealt, and that can't necessarily be changed, but there's a lot of ways here where we can actually take control and choose habits that do more prevention. So coronary artery disease, by the way, is a major risk factor for stroke, and it goes both ways as well. So this is why it's important also, if somebody has had heart disease, we'll make sure there's an investigation done to make sure they're not at risk for a stroke, and vice versa as well too. So I love this slide. This is another great one. If you want to keep a screenshot of this, it's called Life Simple 7. So these are the main risk factors that we talk about for heart disease. So again, the desire is to modify these agents before heart disease is diagnosed and before we've missed the boat, and that's what we constitute for primary prevention. But unfortunately, sometimes we miss the boat either on either end, and now we'll work on tightening these risk factors even afterwards. Because guess what? Even after an event like a heart attack or angina or a mini stroke, anything like that, even after that point, these are still the same risk factors that have not gone away. They're still going to be present, and they need to be optimized and medically treated as much as possible. So number one, controlling the cholesterol. So when looking at the cholesterol profile, if you ever looked at your own labs, there's a full set of 4 different things that we're looking at, which include the total cholesterol, the LDL, which is the bad cholesterol, the HDL, which is the good cholesterol, and then the triglycerides as well. And these are all independently important in different ways. Out of those, LDL, which is the bad cholesterol, is the one that's correlated the most with heart disease and events. So never leave your doctor's office without knowing what your LDL is, and ask that, and, save it so this way you can track it over time too. The HDL is a good cholesterol. Unfortunately, if you don't have a lot of good cholesterol, that's a tougher one to raise. The only ways to really raise it are exercise and red wine. So there you go. I gave you your green light there in case anybody needed it. But triglycerides, even though they're part of the cholesterol panel, triglycerides are actually created a lot of times from carbohydrates. So that's, carbohydrates, traditionally we think of them in terms of weight gain and in terms of raising the glucose, but unfortunately they raise triglycerides, which also can be a risk factor in addition. Eating better. So out of the diets that are out there, there is one diet that actually has more scientific evidence behind it in terms of preventing heart disease and events in the future, and that is the Mediterranean diet. And I, try not to be the type of physician who says, hey, have 2 ounces of almonds and a quarter cup of these beans and you'll be good to go. But I do think the Mediterranean diet offers really good guidelines just in terms of vegetable content and proteins, nuts, and a lot of good recommendations. So definitely take a peek at that when you have a minute. Losing weight, I gave you some nice evidence in terms of obesity and BMI correlation. Getting active. So what does that mean? Is, going up the stairs twice a day with my laundry basket, is that enough exercise? So what's recommended from the studies is a total of 120 to 150 minutes of good cardiovascular exercise a week. So that means if you can do that in 3 days, more power to you. If you can do that over 5 days and spread it out, then that's fantastic also. Managing the blood pressure and, working with your physician to just make sure that that is within the goals for you, because for everybody, sometimes that goal can be different depending on your age, whether you have diabetes or not, and different situations. Reducing the blood sugar, and this means diagnosing and attacking even when it's pre-diabetes before it turns into full-blown diabetes, and stopping smoking, as we talked about. So, all right, that's all I have, and I believe we are open for questions.
Thank you so much. Every month that we have these presentations, they're just getting better and better. So we do have a little bit of time for some questions. If you want to put them into the chat, you can do that. I'll start. I have a question. Deanna, you mentioned insurance a couple of times. These medications, the new ones, they seem pretty costly. Am I going to run into a problem?
So the issue is that you have to document everything that the patients have been on. So if you come in and you've not been on any of the older medications, you most likely, the insurance will not approve the new medications. But most patients have already tried a Triptan or 2 and have usually tried something else. If you've been on an antidepressant for any other reason, for example, then I include that in patient has had a trial of an antidepressant medication. If you've been on a blood pressure medication for any reason whatsoever, then I include that in patient has been on that and still had headaches. So that will count at, towards your headache, whatever. And what I do is I put that in there. We just talked about that this morning. How do you document that? I actually put it in their past medical history section in our EMR so that it carries over every time to every note, but it's always there so that the insurance or whoever always sees it. The patient has tried and failed this, that, and everything, so that it's always there. Some of the companies that, with these newer medications, because they know that they're not on the formularies yet, they have, depending on the patient's insurance, if it's not a government sponsored plan, they have, coupon cards that will cover it for $10 a month or no copay for a year. So the company will actually sponsor the cost for about a year or so, depending on what they have for their insurance.
Okay, thank you.
Mm-hmm.
Other questions from anyone? I'm going to unmute you all. You can unmute yourself if you want to ask a question.
I just want to ask you a question as well too, especially about the injectable medications as well too. How are your patients finding that? Are they finding it to be burdensome, or it's been very helpful for them, or what's been your feedback?
No, so initially 2 out of 3 of them came in a syringe with a needle, which was very, off-putting for some of them. But now that they're in the pen that's preloaded. Most of the patients, once they get to that point, the headaches have been so debilitating because initially they had to have more than 15 days a month of migraine. So that's more than 50% of your time where you're having a headache. So that's a lot. So they're usually taking so many medications already and their life is so disturbed that for them to ask them to give themselves one push button shot a month, they're like, give it to me, I'll take it. So for most of them, it's been really, really good. Sometimes they get some injection site soreness. So I tell them to, ice before, ice after, and that's usually fine. So I would say 90%, more than 90% of the patients, it's been so well received because of the effect of it. I've had maybe 2 patients that have had to stop it because of constipation or injection site soreness, like a handful of patients. But otherwise, the effect has been so good. Because most of them have already been through all of the other non-specific medications and had so many side effects from them, that they're more than happy to do the once a month shot. Some of them have a family member do it for them, like, that they don't want to do it, but literally it's you push the button, you wait 10 seconds, and that's it, it's over. So.
Great. Thank you so much for that. We do have some injectable medications for cholesterol as well. And I think one of the companies are in common where they also produce one of the products that you had mentioned as well too. But it's always a little bit of a challenge, but sure, if it's going to make a quality of life difference, I think everybody's willing to do it. So
Yeah.
Thank you.
I think the difference with that is that I guess for better or worse, you can't feel high cholesterol until it's too late and you're having that, thumping chest pain. Whereas the migraine, they're feeling that, many days a month. So they're probably more willing to treat that than they are the cholesterol, I would guess.
Yeah, you're 100% correct.
Okay, I think we have time for one more question. Dr. Shaikh, thanks for so much a great presentation. What is the most effective technique you have found in helping patients alter their diets and make significant lifestyle modifications? I imagine many patients are resistant to these suggestions, so I'd love to hear how you approach these conversations.
Yeah, it is probably the toughest conversation, but also the most common conversation that I have in a day with multiple patients. So great question. So I try to keep it simple because everybody does have a lot of different things going on in their life and they don't need to hear an entire recipe from me on anything either. But I often start with just making sure that, 50% of the plate is fruit or vegetables because a lot of us grew up with the food pyramid being inverted, right? With all the grains at the bottom and the carbs. And we know over the years where that took us. But I try to implement just, half the plate being fruits and vegetables, having a tall glass of water right before each meal, including a fresh fruit or vegetable as well before each meal. So that way we kind of get the good ingredients in ahead of time. A lot of times thirst gets confused for hunger as well too. And then I try to give also some take home information too. So this way people can kind of digest it, for lack of better words, later too, in terms of either the Mediterranean diet and even just some basic education on what's a carb, what's a protein, because people think that potatoes and sweet potatoes and corn are vegetables and they're not. Unfortunately, they're grains and starches, which just kind of add to the problem. But I start there and I try to also just kind of normalize having the conversation. Sometimes, people may find it, offensive or strange to have that conversation, but the more that we normalize it and talk about it, the more advice we can give each other too in terms of good ways to make better choices.
Well said. Well, I think we're going to wrap it up to give people time to get back to their 1 o'clock requirements. So thank you very much for your presentations. Thank you to our audience. You hung in, and it was really, you got great information from the beginning to the end, and we'll be looking forward to seeing you again next month. No, actually, we take December off. That's right. We took December off. Too much stress, too many things going on. So we'll reconvene in January. Take care.
Thank you so much for having me.
Have a great day, everybody.